Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree, Chappell, your host, and we are coming to you from EBPOM, Las Vegas. Fortunately, I am joined by my co-host, Editor-in-Chief of Top Med Talk, Professor Monty Mythen. Hello, Monty.
Hi, Desiree.
Also joining us is our friend of the Top Med Talk family, our co-host, Mike Grocott from the University of Southampton in the UK.
Happy New Year to you both.
So we're here with EBPOM, the EBPOM Las Vegas meeting, first meeting of 2021. EBPOM, evidence-based perioperative medicine, been around for a while, hasn't it, Monty?
Since 1997. So we've been doing, I think we're part of the sort of trailblazing international group discussing the sort of concept of perioperative medicine, which has now been defined and is in common parlance. Our iconic annual meeting was in London, and then over the years has extended to Ireland and Chicago. And when we talk about EBPOM Las Vegas, we should probably state the obvious. All meetings are virtual at the moment.
Yes.
But it was supposed to be in Las Vegas with the ASA, the American Society of Anesthesiologists, just before their practice management meeting. So thank you very much indeed for their partnership. But we're coming to you virtually.
One of the topics that we've discussed and a study that we've been following over the year is the Prodigy Study, or the prediction of opioid-induced respiratory depression in patients monitored by capnoGraphY. And we had the opportunity now to catch up with some friends. We have Ashish Khanna, who is an intensivist and anesthesiologist, associate professor of anesthesiologist at Wake Med. Hello, Ashish. How are you?
Hi, Desiree. Hi, Monty. Hi, Mike. At the Wake Forest School of Medicine.
Wake Forest School of Medicine.
Yes. And it's a pleasure to be here and be in Las Vegas and London at the same time, and Southampton. So that's a value of virtual meetings. It allows you to be in multiple places at the same time, in the luxury of your office.
Luxury it is. Yes, agreed. Well, we can always dream. So our second guest, we have Roop, who's an associate professor of medicine at the Cleveland Clinic and the College of Medicine of Case Western Reserve University. Roop, it is so nice to see you again. How are you doing?
Likewise. Hi, everybody. Wishing you guys a happy new year. I'm glad to be here with you guys.
Yeah, absolutely. Well, guys, just before we kind of dive into Prodigy, just take the temperature of how things are looking for COVID. Ashish, what's it looking like there for you guys in North Carolina?
So I recently did a little television interview, and I did make a strong statement that what we're seeing right now is way worse than what we saw in March and April. And I think that's probably the universal truth. Most parts of this country, it was something that we anticipated would happen with winter and with the holidays. And my hope and prayer and silent prayer is that as the vaccination goes out, this is the last of the many surges we've seen. In fact, we've seen so many surges that we're not even calling it a surge anymore. It's a perpetual surge situation. The good news is the vaccination has been fairly well accepted with the medical community. I would say close to 90% of those being offered vaccination, at least in this hospital system here, are getting vaccinated. And, I get my second jab today. I'm standing. I hadn't had any problems. So I recommend everyone to please, follow science, get vaccinated if you can, and we'll get through this.
Yeah, absolutely. Well, thank you for sharing that. Roop, what's it look like up there in Cleveland?
Well, yeah, we are hoping that we're pushing through this plateau phase of this surge, which is the post-holiday surge, and maybe beginning to see some downsloping from here. Our state, if the numbers are correct, has had a steady about 8 to 10,000 new cases a day. The deaths are somewhere between 80 to 100 a day. And it's kind of been on that big plateau for a while now. But I think that we are beginning to see that we might be going down the slope and be on the other side of this, hopefully, of this issue. Yeah.
Yeah, it's the same as in Kentucky. In case for listeners, I'm a CRNA myself, a nurse anesthetist. We're still going strong with our surgical cases. We haven't really turned that down so much, but we are seeing still a fair amount of cases, but it does look like it's plateauing in Kentucky, which we were at a really hot spot for a little while. So hopefully that is the international trend that we're seeing, right? Well, gentlemen, over the past year, we've had a chance to talk to you all about the Prodigy Study. Now, Monty, where can we find the other conversations that we've had?
So you can find them on TopMed Talk. So within our library there, if you look up Prodigy, but also those of you who've been joining in our actual virtual meetings, we've recorded a number of conversations as well that we'll be playing out again soon. And as part of our meeting coming up in Las Vegas, those of you watching now, watching this, if you see what I mean, but there are numerous different touch points for it. But we've been building the story basically. So today we're only going to go very briefly to re-summarize what the study showed us, and then give Mike, who's more recently joined in the conversation as a collective here, and then look at what we could do next, because I think we've done good reflection on what was discovered by the excellent work that was done and published. We now need to decide what we do going forward, because I think we're about to discuss a problem that, unlike COVID-19, it possibly could be largely iatrogenic, something that we have caused to a certain extent by well-intended actions. So I think that's where we should go.
So Ashish, why don't you kick this off for us? Briefly tell us about the study, what you all were looking at, and what you found.
So the study itself, the Prodigy trial, was done in 3 continents, North America, Europe, and Asia. And we enrolled adult patients on the general care floor. Both our intent was to enroll both post-surgical and medical patients who were receiving parenteral opioids and were continuously monitored by capnoGraphY and oximetry-based monitoring. So the monitoring itself included continuous heart rate, oxygen saturation, respiratory rate, and tidal CO2, and a collective index called the Integrated Pulmonary Index. The monitoring was interesting because we blinded and silenced these monitors. Nurses and providers were allowed to do their usual, standard of care, every 4 to 6 hour intermittent checks. And what we hoped to uncover was sort of the burden of respiratory depression that was going unnoticed. And also we wish to develop a risk prediction tool called the Prodigy score that would allow us to estimate, provide some sort of a guidance to the clinician, say, your patient is an increased or usual risk or a low risk for opioid-induced respiratory depression. So 1,335 odd patients in our final cohort, and we developed the Prodigy score. The score itself is simple. It's age, with increasing decades of life beyond the age of 60, male sex, opioid naivety, sleep disordered breathing, and chronic heart failure. So, as I say the score, I think one of the biggest points about the score is so easy, right? Everyone can literally find all of this in a patient's chart. You don't need to go online into a complex calculator or something like that. Easy to do score. Get your score on a patient. There's 3 levels on the score. More than 15 is highest risk. 8 to 15 is intermediate. Less than 8 is low risk. Now, mind you, low risk is not without risk. Low risk was still about 20% or so risk of opioid-induced respiratory depression. So I'd like to tell people that no one is without the risk of opioid-induced respiratory depression. But the hope is, once you do this score on your patients, you can not only think about better monitoring, but you can think about proactive interventions. Be a good doctor or be a good provider for your patient. And that's the simple truth with Prodigy. The headline with Prodigy was that 46% of our patients of the entire cohort had at least one monitor-detected respiratory depression episode that we predefined with certain thresholds, and that those were adjudicated by an independent clinical event committee. So an alarmingly high number of patients we saw with these episodes.
And we were reflecting on it beforehand, Ashish, and might want to come in on this. Your criteria for respiratory depression was, you had to be pretty depressed, to put it bluntly, if you see what I mean. It wasn't they weren't soft criteria.
Absolutely. I mean, and we did that on purpose because we knew that if we're doing blinded continuous monitoring, we're not going to have the ability for a research fellow to sit by a patient's bedside. We wanted this to be real world. So there was going to be a lot of artifacts. So just to name the criteria, we were less than 85% on the pulse ox for a continuous of 3 minutes. we were a respiratory rate of less than 5 for continuous 3 minutes. So if you're less than 5, a low respiratory rate for more than 3 minutes, that is someone who is really, really, bradypneic. I mean, there's no doubt about it, right?
The criteria are strict, and yet the prevalence is very high. And, we would talk a little bit before this conversation about, so it feels like it's higher than I think I see in my practice. But as with many of these things, you then ask yourself, maybe I'm not seeing it. One of the questions I had related, so you've got different geographies, so North America, Asia, and Europe. Were you seeing different prevalence of those criteria across those different geographies?
Yeah, so the interesting part was we saw a slightly different patient demographic, and part of it was expected. The Asian population BMI was more normal compared to the North American population. Asian population was mostly, a lot of them were opioid naive. And in North America, almost no one was opioid naive. So clearly that is a harsh reality that all of us live with. We haven't separately analyzed the Asian population to see if we need to develop a separate Prodigy risk score for them. Part of it is we didn't have enough numbers coming out of Asia that we would develop a separate risk score. But I think that is sort of the next step. That is one of the next steps that we want to focus on. We want to say, okay, are you genetically inclined to have less opioid-induced respiratory depression, or does it depend on what hospital system in the world that I, for example, have I grew up in India. So, if I become a patient tomorrow and have opioid-induced respiratory depression, is it because of where I'm being monitored? Or is it because of my tendency to have opioid-induced respiratory depression, right? So I think that is one of those interesting things we want to answer here.
Roop, was it surprising to you as a hospitalist to see the outcomes for this and that 46% of respiratory depression in these post-op patients? I mean, you see these patients and round on them every day.
I believe it was surprising. 46% pretty much means every other patient who was getting IV opioids was having some sort of a respiratory depression event. But I guess the truth behind this might be that, it's not like all these events actually translate into what we call as hard clinical outcomes. For example, somebody actually requires, let's say, a reversal or an intubation or any of those things. If we look at the background rates of those things, and in the general post-operative population, and you look at the prevalence of like post-op, things like post-op respiratory failure, broadly speaking, we go anywhere from like 5% to, as high as 30, although I wouldn't believe that 30 part, but let's say it's in the range of like 20. So if the hard outcomes and the clinical outcomes are 20%, and it's not surprising in that sense, although I did say that I was surprised to have a 46% individual respiratory depression. It's not surprising to see that was there.
Let's talk a little bit about the risk prediction tool. How do we use this tool and put it into practice so we can start, affecting that number? Ashish, do you have some ideas on this?
So I think very simply speaking, every inpatient in the hospital should have some sort of risk prediction score, right? And Prodigy is an easy to use tool. I think it should be brought into pre-anesthesia clinics, into the post-anesthesia care unit, and for the medical patients into the emergency room, or anytime a patient is admitted into a hospital. Every patient should just have a Prodigy score tied to them, because a lot of patients, 90% of our patients, are still going to get opioids. And in fact, I will make an extension and say, yes, we developed the tool for opioid-induced respiratory depression, but what we're seeing is not just opioid-induced respiratory depression. We are seeing events on the floor for the lack of continuous monitoring or the lack of proactive interventions. So we need to have some sort of guidance for clinicians to intervene early and proactively. Now, whether that be a beta blocker in a patient who has chronic atrial fibrillation before, whether that be a diuretic in a patient who has heart failure, whether that be a respiratory therapist going more into a patient's room and making a patient do incentive spirometry. I think all those things matter as much as continuous monitoring does. So yes, we need some guidance, and we need it at, not just at the floor level, but at other places where a patient touches, in the hospital.
If this was universally applied, and clearly you can have it wrapped into your electronic health record, have you done any work, or are you looking at guidance for opioid prescription? So if you fall into a particular risk band, you get an advisory that comes up and says maybe you should reduce the dose or reduce the dose a bit more, that kind of thing.
We have not done that as yet. The tie-in is if you are at a higher risk, we advise you getting continuous capnoGraphY and oximetry monitoring. Although I do agree with you that the real risk reduction is also then intelligently prescribing opioids. However, I will also say, Mike, again, that, it's not that in a world free of opioids, there is no postoperative respiratory depression. We all know that there's a fine line between an undertreated. So if pain is undertreated, especially in a post-surgical patient, then they're not going to take deep breaths, and then they're going to splint and get basal atelectasis and get hypoxemic and get into trouble. On the other hand, if pain is overtreated, then they get opioid-induced respiratory depression. So I don't have a perfect answer for that, but I do agree that there needs to be some intelligence in terms of opioid prescription practices.
So let's talk about the interventions then, the monitoring that we can do. So they get a risk prediction and they're high risk. You mentioned just briefly some of those interventions. And then Roop, I want to hear from you too about this. What are we doing on the floors to actually then protect our patients if we know that they're high risk?
Preemptively, I don't think we're doing much. Now, there are certain places, like Ashish said, that have telemetry on the floors, which is not exactly respiratory monitoring like ours does. But preemptively, we have nothing. We are always doing things, wiser after the event. So we have these AMET teams and rescue teams and stuff like that. And the intervention actually starts there. So the question really is that, does it have to be that way, that RRT has to be called and AMET has to be called, or can we have some sort of a basal guideline, as to, which of these patients we might have to actually have real continuous monitoring on? The continuous monitoring is not done on the general so-called medical or surgical floors or post-operative patients. And I think that interventions would be then studied. Once we have, for example, we know these are the high-risk patients, or we have decided to monitor some of these patients, if not all of them, and then we could have, what interventions basically got us better results than how we're doing it right now. Right now we are like having an AMET team come in and they either, dismiss the problem as something big or send the patient to ICU. And that's not how things have to be in future.
Yeah. And, we've talked about this again in some of our other conversations. Monty, you may remember this, about the difference between the different monitoring. Because, some people are like, well, we'll just throw a pulse ox on them. Ashish, you've said in your institution, you actually have continuous CO2 monitoring on these patients. Do people understand the difference and why we might go to something like that?
So yeah, actually, we have continuous monitoring here for the last 5 years or so. Interestingly, there is a correction that the only monitoring we don't have is continuous CO2 monitoring, which actually is the most challenging part of continuous monitoring, because we know that end-tidal CO2 in a non-intubated patient, that is the one measurement that's most prone to fallacies and artifact, right? Mm-hmm. The nasal cannula can be on the forehead, can be on your shoulder, can be on the ground, right? Can be anywhere. And patients don't like it. They're not, there's a lot of like, oh, I don't like this thing in my nose. And if I had to make one suggestion, I would say that if the world is listening, people need to develop better ventilation monitors, right? And I think that is one part of monitoring we're missing. Here at Wake, we have continuous heart rate, respiratory rate, blood pressure, oxygen saturation, patient position, and body temperature. And wearing my other hat, I'm also a big proponent of continuous blood pressure monitoring. In fact, I'm right now doing a large cluster randomized trial where we're looking at, 2 separate floors in this hospital that every 4 weeks switch from continuous to traditional monitoring. And we're going to see whether myocardial injury after non-cardiac surgery is affected by the correction of hypotension. So there is huge challenges, but there's some interesting work being done. Yes, Monty, you were going to say something.
Are you doing that with wearables, or the sort of that you can move around with the technology?
Yeah, absolutely. Correct. These are portable monitors, and the patients can absolutely move around. Literally, they have to stay on the floor, but they can walk. They don't have to be tethered to anything, and it's really nice.
And one of the pushbacks we often get on that as we explore greater monitoring is alarm fatigue. Do you have some sort of intelligence built into the system to stop that relentless alarming?
Yes, so I can tell you data from my institution, only about 50% of alarms are accepted. So the way it works here is that if I'm a patient, I'm wearing something right here. If a threshold is breached, then a nurse is carrying a phone or a pager. That nurse gets paged that such and such patient is less than such blood pressure. Only 50% of those are primarily accepted. Now, if you don't accept those, second time it goes, it'll go to 6 other nurses. The third time it goes, it'll go to your charge nurse, right? So we have an escalating system built in place. What we also have built in place is that every month we do an analysis of our alarm data. And with the device company and their engineers, we say, okay, if we leave the oxygen saturation at 85% as our alarm threshold, these were the number of alarms per patient per day that we were seeing. Then we allow for a delay. So we allow for a delay at the level of the monitor. So you can add a delay here. Then you can allow for a delay at the level of the phone that the nurse is carrying. So we've adjusted alarms and delays specifically, and we've come to about 3 to 4 alarms per patient per day. Now, that looks like a very low number, but let me tell you, an average nurse carries about 8 patients on the floor every shift. Mm-hmm. So 3 times 8, there's like 25 alarms per patient per shift, plus technical alarms, plus other reasons that the patient is pressing the call bell for. It's still a lot of alarms that are going off, but we're still trying to minimize them.
My last comeback on that is if you'd be prepared to let the patients turn their own alarms off, because I always kind of think you're probably okay if you can turn your alarm off. Is that wrong to assume that?
I'm okay if they do that from the respiratory side. That's why I'm the blood pressure side bothers me, because we all know that you can be asymptomatic with a MAP of 55. Now, the question is that okay for your myocardium? You can be totally asymptomatic with a MAP of 50, and would you just go on turning that alarm off? But that's probably not the right thing to do.
Yeah. Roop, how do you feel about this?
If we talk selectively about postoperative patients, a few things have been already established. One is that we're not actually capturing the burden of postoperative hypoxia to begin with. What I mean by that is that Ashish and his group did a study some time back where it came out of the Cleveland Clinic institution, which was continuous blinded postoperative oxygen saturations were measured by pulse oximetry. And there were prolonged pauses of hypoxia in patients. There were multiple episodes, and that's what's basically the burden of hypoxia. The second thing is that as far as the hypercapnia goes, there's literally nothing. We're just waiting for the patient to be obtunded or non-responsive. And then again, you have to be lucky if you're in a teaching institution, if the first person who goes into the room actually picks the problem exactly what it is. So there's no question that continuous pulse oximetry and of course a refined form of capnoGraphY is definitely needed. I do not believe that I'm open for universal monitoring, continuous monitoring of all postoperative patients. It's been proposed before by the Patient Safety Foundation. There's a lot of merit to that concept. What it lacks is probably practicality. But yes, definitely there are patients out there who are not being continuously monitored for their hypoxia, are all being monitored for their hypercapnia. And this is very true. If there's a patient population, it's very true. On the general medical floor, it's the postoperative population. Yes, Mike.
Do you think that lack of practicality is around the cost and the device complexity, or the sort of issues that Monty was alluding to, which is the information overload? Because certainly we're seeing sort of sticking plaster style disposable wearables that are coming through at only a few dollars. So you could see that the technology would be up to it.
Yes, I think it's mostly around the cost. I wouldn't be shy of saying that, although I'm not, when it comes to the cost world, I'm not one of the decision makers in that. But clearly you see that when you try to push certain things, cost is going to be the big factor. But I would say that it's also going to be compliance. It doesn't mean that you have the wherewithal of having an excellent, there are places in the US that are doing continuous monitoring, not many, but they have been doing it for a while. I think then the question is compliance. Is your equipment or monitoring equipment, whatever you're using, is it going to be patient friendly? And are they going to be in their post, at least in the first 24 hours? Are they going to be keeping it on? So those are sort of the challenges, and I think that if we do universal, those challenges will multiply. If we do patient focused, we might have a higher signal and less noise.
Yeah. How do we work collectively and collaboratively with anesthesia and hospitalists and nursing to put this prediction tool into practice and establish protocols for our patients? Because obviously this is an issue. Ashish, I'll start with you, and then Roop, I'll go to you.
I think putting the tool into practice is really simple. The tool doesn't cost anything. It's there. Anyone can use it. I think we need hospital information technology partners to really jump into this, because in the best case scenario, the tool should be seamlessly part of your electronic medical record. It should not be a piece of paper sticking somewhere, but it should just be in the EMR. In fact, I'd go a step ahead and say the tool is so simple that the EMR should be able to calculate it right then and there. As soon as you hit submit, or as soon as you hit accept on an opioid prescription, your Prodigy score should pop up. And I know there's, different hospital systems are using different EMRs in the US, and that's one of the barriers. But I think that's the easy part. The next part is the operations part. What do we do with the tool once it's there? I think now is the time, I call on all the interested perioperative medicine fellows, trainees, interested young scientists, take this up, externally validate the Prodigy tool in different patient populations. Make this your QI project. Make this a cost benefit project. This is the time to play with the tool and add to the science behind the tool. And I'd actually love to see some of those things come out, and we'd work with you. So use it, implement it, use it. The operations side will pick up once we start using it as a research tool, research methodology tool as well. The final frontier is building on continuous monitoring. And that will be the most difficult part to sort of navigate. But again, I'm hopeful that we're making progress, and we're going to get there at some point.
Roop, what do you need from us in this community to get this out to the hospitalists and those working in the hospital taking care of patients on the floor? How do we collaborate and make this work?
Starting right from the pre-op state platform, if the pre-op folks are familiar that there's a tool like this that exists, and then using it through the intraoperative period, then obviously I don't see how there will be hospitalists on the surgical floor that will say, oh, I don't know what this tool is or what it's supposed to tell me. Yeah. Even if we don't use continuous monitoring at this point, and we have a lot of these patients checkmarked for this risk predictor tool, we can roughly correlate the outcomes even without having, at least clinically, the people can talk amongst themselves with the Prodigy score of 11 or whatever was, my patient had this. So this is sort of like getting the feel. And right now, it seems like it's all post-event awareness, not pre-event awareness.
Oh. I can see from the perspective too, as a nurse, this would be a great nurse QI project or like a capstone project, because I can see this really in handoff every time we hand off to the next provider, it may not be physician to physician, but if we start educating from the nurse level too, and really pushing that on as every time you hand off on this patient is at risk. We need to make sure we watch that. So bringing kind of the multidisciplinary team. Monty, do you have a comment on that?
Well, I think you should talk to your vice president of quality about that. That's you, isn't it?
It is. Well, talking with our team, our whole team, CRNAs, physicians, PACU nurses, and then the PACU nurses going on to the, reporting to floor and ICU nurses, I think will be really important. So, well, gentlemen, thank you so much for another wonderful conversation about Prodigy. Definitely looking towards this space because it sounds like hopefully in 2021, we'll hear some more. Any other studies in the pipeline that you guys are working on as far as some of this monitoring stuff?
There's actually a paper coming out that's actually looking at, it's a deep dive into opioid prescription practices across the world. Help us answer some of those questions that were asked initially. That should be coming out any day now. And then a series of cost-benefit analyses. And they actually help us establish, say, for an X percentage reduction in respiratory depression, what was the break-even point for an investment into continuous monitoring. And that is what the Vice President of Quality and Patient Safety wants to know as well, right? Along with the other administrators in the hospital, right? So I think that is important. A very quick point I want to make is people often tell me, the so what factor, so my patient was hypoxemic, 85% for 10 minutes, but they're still okay. They're home now. Everything's fine. They're used to it. I think we have to move away from this culture that we have ingrained in us. So what? It's okay. They're fine. They're walking, talking. Everything's okay. I think it is as simple as that. You have continuous monitoring. You have the ability to understand patterns and change in patterns. Then you should intervene based on those patterns. You cannot just let anyone be hypoxemic because they tolerate hypoxia. That's not the way to do it. I would do that for my family if my family was recovering on the general care floor, and you'd probably not do that for your patients either.
Yeah, very.
And I would add to that, in the medical patient with the medical substrate of like 2 or 3 organ systems that are chronically sick, the ability to tolerate that hypoxia can translate not only into a respiratory complication, but it can translate into any other complication, which will be invisible to track it back to hypoxia.
Yeah.
So but just to be clear, we'd all tolerate 88% saturated in a very sick, critically ill patient who'd been hypoxic for a while. It's a different scenario to the post-op respiratory depression. So it's a complicated equation, but absolutely.
Right. But that's where we need to, I will still say that this is not the end. This is just the beginning. That's why we do large trials to really see, we talk about the effect of hypotension that's affecting myocardial injury, all that's been done. Is respiratory depression also affecting the myocardium? I don't know yet, but I don't know because I haven't done those experiments, and people need to start doing those experiments.
Yeah.
So I think we said earlier on, Desiree, the Prodigy study is published in Anesthesia and Analgesia in the October edition. It's in the show notes and easy to find by an online search and or going via a search engine such as PubMed. So it's all there, peer-reviewed for people to have a look at.
Yeah, absolutely. Well, gentlemen, thank you so much. Good luck in your future research that I know that you're doing. And good luck on the COVID front. And, I hopes and prayers that that's all moving along and we're going to get to a different place by the end of 2021. Let's hope. Thank you all so much. Cheers.
Thank you, guys.
Thank you.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.